Thank you very much. It's indeed a great pleasure as well as honor to be here. And more gratifying is perhaps to sort of chair a session in which none other than Professor Sir Robin Murray, Fellow of the Royal Society, is going to address. I don't think that I should waste uh, time in introducing Robin Murray, because it will take me ages to introduce him if I really want to introduce him properly. But suffice it to say that he is a legend. He is well known for his research in schizophrenia. And not only that, the amount of effort he has spent in mentoring people and developing research resources is commendable. So, with these few words, if it is permissible, I invite Professor Robin Murray to deliver his talk.
Good morning. Thank you very much. And thank you for the honor of participating in your Diamond Jubilee celebrations. It's a great privilege to be part of this and celebrating your distinguished hospital and track record. So I'm going to continue on. You can see my slides okay?
Sure. Yep.
Yep. So I'm going to continue talking about preventing psychosis. And you can see that we are in a hotel room, and my wife is wandering around in the back of the hotel room packing our clothes, because we're returning from Italy to London. But I should say that my focus is on prevention of psychosis, and we have to give credit to the two people who first started thinking about prevention of psychosis in modern times, and that is Pat McGorry and Alison Young from the University of Melbourne. And they developed what were called initially prodromal clinics for young people with the at-risk mental state who were considered at high risk of developing psychosis. Now, these are people who are not frankly psychotic, but perhaps they may have thought they heard a voice. They're not very sure. They may think the other young people are against them, but they're not very sure. Their behavior may have deteriorated. And so they have these criteria for the at-risk mental state, and people who are referred to their clinic with and qualified as having the at-risk mental state, they claimed that 40% of them would go on to develop a psychosis in the next 2 years. Now, these clinics have become very popular throughout the world, and as they become more popular, more people who are less classical have been referred. So the proportion who now go on to psychosis is nearer 15%. But the purpose of these clinics is to reduce transitions from the at-risk mental state into psychosis. And so the detection and treatment of young people with the at-risk mental state has become a popular prevention strategy, with the creation of prodromal clinics in Australia, the UK, Europe, and North America. I don't know about India, but perhaps you'll tell me about this. So these clinics have been very valuable for research, because you can identify and study people who are going on to develop psychosis before they get antipsychotics, before they become chronic, and therefore it's much better to see the actual biological, better to do MRI scans and cytokines and cortisol levels on people before they get antipsychotics. So universities have done very well, and lots of papers have come out regarding these clinics. But there is the question, are they effective? And do they actually stop people developing psychosis? And there's contention about that. ethically, it's not really possible to give everybody who comes to one of these clinics an antipsychotic, because if there are 100 people are referred and only 15 of them are going to develop a psychosis, you would be giving antipsychotics to 85 people who would never develop psychosis. So it's been more psychological therapies, CBT, that's been used in supportive care. And there's some uncertainty as whether they're effective. But the most important question, which you've been discussing in the course of this symposium and this conference, is for something to be useful in prevention, you have to reach a significant proportion of those at risk. And that's what really we did, or my colleague Alicia Ashanakina did. And usually the studies of at-risk mental state clinics, prodromal clinics, you start off with the clinic and you follow people up subsequently. But what we did was, in South London, we identified everybody who developed psychosis for the first time, over 2 years. And there were 338 people who developed psychosis. We have a lot of psychosis in South London. And we looked back to see how many of the 338 had ever gone to our prodromal clinic, which is one of the most well-developed in the world. And out of these 338, only 55 had ever gone to the prodromal clinic. The vast majority had never heard of the prodromal clinic. So that was 16%. Well, that's not unreasonable. You're addressing 16% of those who will develop psychosis. But in fact, of these 55, 41 of them were already psychotic. So actually, only 14 people came to the prodromal clinic, met the criteria for at-risk mental state, and went on to develop their first episode of psychosis. You're only getting 4% of all of those who will develop psychosis. So this is hopeless from a public health point of view, and from an economic investment point of view. This suggests that these prodromal clinics are not going to, well, even if you got twice or 3 times as much, you're still only getting 12% of those who will develop a psychosis. So from a public health point of view, this is not useful. So we wrote a paper, which you can see in the bottom right. Only a small proportion of patients with first episode psychosis come via prodromal services. And we sent it off to journals, and it was turned down by 4 different journals with very nasty comments, very vituperative comments. This was an unethical study. This was a badly designed study. It was poorly carried out. The results are misinterpreted. So we really got the worst reviews I think I've ever had. And of course, what was the reason for this? The reason for this is the editor of the journal gets an article about prodromal clinics, and the editor says, oh, this is on prodromal clinics. I'll send it to an expert in prodromal clinics. So he sent it to an expert on prodromal clinics. Of course, all these experts are very enthusiastic about prodromal clinics and do not like a study which says that they're not very valuable. So it was only on the 5th journal that we managed eventually to get it published in a journal called BMC Psychiatry, which is an online journal, which we have, where you have to pay to get it published. So eventually we got it published, but it wasn't exactly in the Lancet or the New England Journal of Medicine. So by this time I was quite annoyed that the referees, the people running prodromal clinics had been so negative. So I persuaded Alicia to write a review for Psychological Medicine with a rather inflammatory title, saying the at-risk mental state clinics for psychosis, an idea whose time has come and gone. And at the same time, Stefan Moritz wrote an article saying that these early detection centers for psychosis, they should be renamed because they catastrophize a future. So some young people will be coming to this clinic and quite liking the clinic and getting some help. And they'll ask one of the other people attending, why are we coming to this special clinic? And the other person say, well, this is because they think we're going to develop schizophrenia. So this is very alarming. So there was quite a lot of criticisms of these prodromal clinics. So Alison Jung and Pat McGorry wrote responding to criticisms. There was another commentary from Malley and Company. Then almost everybody who was running a prodromal clinic in the world, particularly across the United States, wrote in saying how wonderful prodromal clinics were. And then we wrote another article summarizing our point of view, saying these at-risk mental state clinics, well, they're all right, they're good for research, but they're not going to prevent psychosis. We should move on to universal primary prevention. And to give him credit, Pat McGorry has taken on board these criticisms, and now they have moved not to prodromal clinics for psychosis, but to developing youth mental health services. And I think this is much more sensible. You have a clinic to which any young person can be referred, whether it's anxiety, depression, or drug abuse, or possibly a suspicion of schizophrenia, and they can be treated. So this is a much more economically and clinically sensible approach than these prodromal clinics. So if we suggest that we should go on to universal primary prevention, how would we do that? Well, perhaps we can learn a little from cardiology. And Mary Cannon and I wrote a paper in World Psychiatry on this issue. So if you think of the approach to heart attacks that the cardiologists have taken. So people who develop heart attacks often have angina before they develop the heart attack. And then before that, they often have high blood pressure or cholesterol. But essentially, the preventive approach is based on diet, exercise, and no smoking. So if we think of psychosis in the same way, high-risk mental state, the prodromal clinics are dealing with people with the equivalent of angina. By the time you get angina, you're very likely to develop a coronary artery disease. It's very late in the day. And people who are on the pathway from psychosis, each pathway to psychosis, by the time they get at-risk mental state, it's pretty near to psychosis. So it's better to go earlier, the equivalent of looking at high blood pressure and cholesterol. And so there now are attempts, for example, by Mary Cannon in Ireland or Iris Sommer in Holland, to identify children who are at risk of psychosis. Now, children who develop psychosis are more likely to have minor psychotic symptoms, more likely to have neurocognitive difficulties, more likely to have anxiety, more likely to have developmental delay. But each of these things, although statistically significant, is not sufficiently powerful to say we identify you because you're at high risk of developing psychosis and we're going to try and prevent it. But if you do surveys and you identify people who have minor psychotic symptoms and neurocognitive abnormalities and anxiety and developmental delay, then these are the ones who really need a support and help to see if you can avoid them developing serious mental illness. But best of all is a public health approach to look at the risk factors for psychosis, the equivalent of getting people to stop smoking tobacco to help prevent heart disease. So can we carry out primary universal prevention for psychosis? Universal prevention targets the whole population. Public education to avoid exposure to a risk factor. And this has been most successfully employed for tobacco smoking, as you know, which is greatly decreased, except in China. So first of all, we need to identify the risk factors for psychosis, and then we need to have cost-effective interventions. This is a meta-analysis by Evangelos Vassos, the environmental risk factors for psychosis, we now know these very well. When people say schizophrenia, psychosis, these are disorders of unknown etiology. That's rubbish. We know the risk factors very well, just as we know the risk factors for heart disease. So the risk factors are obstetric events, being premature, being hypoxic at birth, doubles your risk. Being abused as a child, not good for any mental disorder, which trebles the risk. Being a migrant or somebody from an ethnic minority doubles the risk. Being born in a city, at least in Northern Europe, and being exposed to recent life events. Work by Paul Bebbington showed that if your wife dies or if you lose your job, you're more at risk of depression. But if you're beaten up in the street or you're bullied at work, you're more likely to, these intrusive life events are more likely to precipitate psychosis. And cannabis use is the biggest risk factor in the West, at least. So we can think of, can we intervene? And here we come to some of the studies of incidence. And of course, one of the most famous study was the WHO collaborative study. And you and your colleague, or your colleagues participated in this. And on the right-hand side, you can see the narrow definition. I'm sure you all know the study. The narrow definition of schizophrenia did not statistically vary in the different centers, although it did vary, as you can see it, but the numbers weren't big enough. However, and most of the attention was directed to this fact that there wasn't a statistical difference. But in fact, as we now realize, the important point about this study was in the broad definition of schizophrenia, there was quite considerable definition, quite considerable variation. And we now know that this is the case across the world. And you can see that Chandigarh was interesting, and many of your distinguished colleagues participated in this study. And the incidence was quite high in Chandigarh. And one of the most interesting things was that the incidence seemed to be higher in rural areas than in urban areas. And this ran against the evidence from Northern Europe that urban centers had higher risk than rural areas. And so this was regarded as a bit odd. But I'll come back to that in a second. Oh, I should say, I understand that I'm actually at a conference in Italy where Norman Sartorius is also there, and he told me that he, of course, was talking with you a couple of days ago. So my point is that if we have variation in the incidence of psychosis, can this give us clues regarding the importance of risk factors? So here is a big study that we carried out across Europe. And this is looking at the incidence of psychosis. This was a very expensive study, 12 million euros. And everybody was trained in the different centers, 16 centers, to identify all cases of psychosis in each of the sites. And if you're thinking, well, I'd like to go to Europe, I'm going to save up to Europe and go to my holidays to Europe. But I work every day with psychotic people. I'd like to go somewhere where I'm not going to meet many psychotic people in the street. Where would you go? Well, you would go to Southern Europe. You wouldn't go to London or Amsterdam or Paris, because these are the places with the highest incidence of psychosis. London, 61 per 100,000. That the Chandigarh rates were running about 40 per 100,000 back in the WHO study. Amsterdam was 47 per 100,000. Paris was 44 per 100,000. And you can see that in England, Cambridge was much lower. Cambridgeshire is much lower, so the more rural area. Cambridge is a little place, and the country area was included here. Much lower incidence than in London. In Holland, Amsterdam had a much higher rate than Leiden, more rural area, and Clermont-Ferrand in France, a rural area, much lower rate in Paris. So this is running against the Chandigarh finding. But in Southern Europe, there was no effect of cities. So, for example, here is Barcelona. Well, in Southern Europe, the rates were much lower. And here is Barcelona, a very big city. The rate was only 12 per 100,000. And here is Palermo, another city in Sicily with over 1 million people. And the incidence is 11 per 100,000. My wife, Marta de Forti, she is from Palermo, and she now works in London. And she said she did a very risky thing by moving from Palermo to London because she's increased her risk of psychosis 5 times. There's been a lot of discussion. Did people miss psychosis in Southern Europe? No, they didn't. To get these figures, the people in Sicily would have had to miss 5 out of 6 people with psychosis, which clearly is not the case. So the incidence of psychosis is higher in the big cities in Northern Europe than it is in Southern Europe, and higher than in many of the WHO, most of the WHO rates of Sartorius and colleagues. So what is the reason? Well, one factor is migration, because migration has been a big issue in the northern cities for very many years. Migration is only becoming important in Southern Europe now, but we looked at particularly at the prevalence of high potency cannabis, and this is a study by my wife Marta de Forti, and we've taken out migrants. So this is just the natives of these different countries, and here the blue is the psychosis incidence. London, Amsterdam, Paris are still the highest. Barcelona, Palermo are low. And you can see this is the prevalence of daily cannabis. And you can see that it tracks the incidence of psychosis pretty well, except in Madrid, where there seems to be more cannabis consumption than you would expect. The reason for this is that in Southern Europe and in Madrid in particular, the cannabis is old-fashioned and has a low level of THC, the active ingredient. In London, the active ingredient THC is about 16%, and in Amsterdam, it's about 25%. So this is evidence that goes along with a lot of the other evidence that heavy consumption of high-potency cannabis increases your risk of psychosis, and that this is a sufficiently big issue in the West that it distorts the occurrence and increases the occurrence of psychosis in those countries where high-potency cannabis is very common. So in London, for example, 2/3 of young people have smoked cannabis, whereas in Palermo, it's a very much a lower proportion. However, you'll think to yourself, well, this is just one study, and it could just be a statistical artifact. Well, here is another study, completed, called Intrepid 2, and this was headed by Craig Morgan, but involved colleagues in Kanchipuram near Chennai in Tamil Nadu, and Dr. Tara and colleagues from there. It involved colleagues from Ibadan in Nigeria and colleagues from Trinidad. And we repeated the same sort of study as across Europe. And I should say, of course, the Indian center was a rural center. It wasn't in urban Chennai. It was nearby. This has been published last year. So here is the incidence in Kanchipuram, 20 per 100,000, quite like Southern Europe. Here is men and women, not much difference. Here is Ibadan, and again, really quite low, again, like Southern Europe. And here is Trinidad. Oops, I've lost my pointer. Here is Trinidad, much higher, 59 per 100,000. And in Trinidad, half the population have come from Africa and half the population have come from India. And here is the incidence in African origin people, 85 per 100,000. Here is the incidence in Indian origin people, 43 per 100,000. So what could explain this? Why would the incidence be so much higher in Trinidad? Well, what about looking at cannabis? So in the black is the incidence of psychosis, so really just what we've already seen. Here is the prevalence of cannabis use in the normal population. You can see very unusual in rural Tamil Nadu. Ibadan, a bit more common, but in men, not very common. But here it is in Trinidad, very common. Cannabis use, very common, particularly in men and particularly in men of African origin. And of course, that's the group who have the highest incidence of psychosis. So that's an incidence of about 85, 90 per 100,000, very high. Cannabis consumption in Trinidad is very common, and it is a very potent cannabis, about 25% THC. So the point I'm making is that these epidemiological studies can show us in different areas what are the important risk factors. So in some centers, it may be there's too much child abuse. In other centers, it may be that migration is an issue, and therefore we should try and help migrants and not discriminate so much against them. But in other centers, the big problem pushing up the incidence of psychosis is cannabis use. So I'm conscious that cannabis use is a much less of a problem, particularly in India. You don't have as yet high potency cannabis, but all bad things, or many bad things, stem from the United States. And sadly, I think a cannabis use and a more liberal approach to the use of cannabis is spreading all across the world. And one of the unfortunate consequences of this, I think, is that we may well see an epidemic of psychosis starting in the United States, but spreading across the West. And I hope you manage to avoid it. But I think we now can address universal prevention. We know what to do. We just have to persuade the politicians to do something about it. So thank you very much for listening.